In this presentation, we will take a closer look at enteral nutrition, more commonly known as tube feeding. Enteral nutrition, or tube feeding, is a method of providing nutrients when an individual cannot meet their nutritional requirements orally. Tube feeding formula is administered into the gastrointestinal tract by way of a feeding tube. So who is a candidate for tube feeding? Individuals who have a functional GI tract but are unable to consume food safely or by normal means due to a clinical or surgical condition. Others may be receiving tube feeding to provide supplemental calories. These individuals are able to eat but are not consuming enough calories to meet their nutritional needs. Some patients will eat by day and receive tube feeding by night. Parenteral nutrition, by contrast, is a specialized form of nutritional support given intravenously by an infusion pump to patients who have significant dysfunction of the GI tract. TPN stands for Total Parenteral Nutrition. It is a specialized formula prepared in the hospital pharmacy and given through a central line. PPN stands for Peripheral Parenteral Nutrition, which is a less concentrated solution. It can be administered through a regular peripheral IV. You will learn more about parenteral nutrition next semester in your lecture course. So to be clear, enteral nutrition means the delivery of tube feeding into the GI tract, and parenteral nutrition means the delivery of TPN or PPN by way of the bloodstream. Both provide nutritional support, but by very different routes. These two formulas must never be confused. Feeding tubes can take several routes to the GI tract. Some tubes end at the stomach and others in the intestines, either the duodenum or the jejunum. Some tubes are surgically placed directly through the abdominal wall, while others are passed through the nose and advanced either to the stomach or intestines. This slide illustrates the different feeding tube positions. It's very important to know where your patient's feeding tube is located. Is the tip of the tube in the stomach or in the small intestines? If the tube is in the small intestines, this position is sometimes referred to as post-pyloric, as it is beyond the pyloric sphincter. We can group feeding tubes into three general categories: large bore, small bore, and surgically placed. Let's look at them one by one. The Salem Sump nasogastric tube is the standard large bore tube. As you know, its primary purpose is decompression. It's not a desirable tube for feeding. However, you may see it used on a temporary basis until something more long-term or permanent can be placed. The small bore feeding tube is a soft and flexible tube placed through the nose or mouth and advanced to the stomach or small intestines. The small bore feeding tube is used for the administration of feedings, water, and medicine. It can stay in place for up to 4 weeks, which gives the healthcare team thinking time to figure out the patient's long-term nutritional needs. If the need for tube feeding continues beyond 4 weeks, a PEG or a PEG would likely be the next step. Please note the advantages and disadvantages associated with the small bore feeding tube on this slide. Small bore tubes are commonly referred to as Corpacs. Corpac is actually a brand name. Corpac Med Systems makes the most commonly used small bore tube. Because they are soft and flexible, sometimes you'll find a wire stylet or a guide wire sits inside the tube, giving it rigidity for insertion. Once placement is verified, the guide wire is removed. On the right side of the slide, you can see an infant with a Corpac in place. Individuals of all ages receive tube feeding. PEG is an abbreviation for percutaneous endoscopic gastrostomy tube. This abbreviation tells us how the tube is placed and where the tip is. Percutaneous means the tube is placed through the skin. Endoscopic describes the endoscope, a lighted instrument that is used to facilitate insertion of the tube. And gastrostomy describes a surgical opening in the stomach. A PEG tube, on the other hand, is a percutaneous, endoscopic jejunostomy tube. This feeding tube's tip is in the jejunum, which is the mid-portion of the small intestines. These types of tubes are either long-term or permanent. The surgically placed PEG or PEG is held in place by its design. There is an internal bumper and an external bumper. Once the PEG insertion site heals, there is usually no dressing required. It's left open to air. When a dressing is in use, however, refrain from placing dressing material under the external bumper. Doing so will cause the tube's internal bumper to embed itself into the gastric mucosa, which can cause erosion of the tissue. So, what are the nurse's responsibilities related to feeding tubes? Well, in some agencies, nurses are responsible for inserting large and small bore feeding tubes, less commonly on the small bore. Sometimes more sophisticated technology such as fluoroscopy or electromagnetic tracking device is used to insert small bore tubes, especially when they're going into the small bowel. Advanced training is required when using these type of imaging devices. Nurses must pay close attention to the position of the tube, using evidence-based practice to confirm and document its location in the GI tract before each and every use. If feedings are administered in the wrong site, for example, the distal esophagus or even the stomach, in a patient who requires a small bowel feeding, the risk for aspiration is greater. Maintaining patency of the tube falls 100% on nursing. Proper use and routine flushing of the tube with water prevents blockages. Also, appropriate handling of medications administered down the tube is critical. Medications that are not diluted properly or mixed with tube feeding or other medications could turn into the consistency of cement, causing blockage of the tube that cannot be undone. Nurses are responsible, therefore, for knowledgeably administering tube feeding, water, and medications down the feeding tube. And lastly, nurses must prevent complications, most especially pulmonary aspiration, which is the most serious and common problem associated with tube feeding. Prevention of aspiration is the nurse's #1 priority when it comes to tube feeding. As stated on the previous slide, nurses must vigilantly assess the position of the feeding tube. X-ray confirmation is mandatory after the initial insertion of the tube. However, on an ongoing basis, the nurse must rely on assessments that can be done at the bedside. The numerical markings on the outside surface of the tube serve to alert the nurse to movement of it. Noting that the documented marking at the nose has not changed is a vital assessment. Assessing aspirate appearance and pH is complicated by the presence of tube feeding. Tube feeding will alter the appearance of the aspirate and elevate its pH, so these placement parameters may not be useful when there is continuous tube feeding running. Only when tube feed has been interrupted for 2 hours or more can the nurse rely on these assessments. But we should not interrupt tube feeding administration unless absolutely necessary. Calories are an essential ingredient for healing. On the other hand, if the tube feed is off for another reason, for example, the patient is NPO for a diagnostic test, the nurse can quickly assess aspirate appearance and pH before resuming the tube feeding when the test is done. So when administering tube feeding to our patients, we must use critical thinking to determine if and when aspirate appearance and pH testing are appropriate and meaningful. Routine X-rays and other types of imaging results will have notations about the position of the feeding tube. Keep a close eye on these results. Volume of aspirate can be used as a parameter of location. An intestinal tube should not produce any aspirate, really. A small amount, less than 10 milliliters, according to Perry and Potter. High volume aspirate in an intestinal tube is an indication that the tube's tip has moved into the stomach. This is a significant finding for someone who is at risk for aspiration and needs the tube to be placed in the small bowel. If there is any doubt about the position of the tube in the GI tract or suspicion that the patient is aspirating, stop tube feeding immediately and call the doctor. Tube feeding formulas can be administered into the stomach or into the intestines. This chart illustrates the advantages and disadvantages of each route. Please take a moment to review it. Gastric administration more closely mimics normal eating. However, intestinal administration is preferred when a patient has problems with gastric motility or when they are at high risk for aspiration. Intestinal feedings must be given continuously on a pump, as the intestines cannot hold a large volume of tube feeding. Remember, the bowel is not a reservoir organ like the stomach is. There are three methods of tube feeding delivery: bolus, gravity, and continuous. With the bolus method, tube feed is administered through the open-ended barrel of a syringe. In other words, it's funneled through the syringe into the tube by gravity. With the gravity method, the tube feeding is placed in a tube feeding bag and infused over 30 to 60 minutes. And with the continuous method, tube feed is administered on a pump continuously. Bolus and gravity feeds are intermittent and timed throughout the day at regular intervals, for example, every 4 or every 6 hours, and a continuous tube feed is given on a pump at an hourly rate. For example, 75 milliliters per hour or 100 milliliters per hour. The pump is programmed with the hourly rate and the tube feed infuses around the clock, or in some cases when it's given for supplemental calories, it may infuse just at night. The doctor's order will determine all of this. So pictured here, we see the three methods: bolus, through the open-ended barrel of a syringe; gravity, the tube feeding has been placed in a bag and it's going in a little bit more slowly over 30 to 60 minutes, and then continuously on the electronic pump. Tube feeding is available in two main systems. There is the open system and the ready-to-hang system, also called a closed system. When using an open system, the one on the left, the top opens and formula from cans or cartons is poured into the feeding bag. A ready-to-hang or closed system that you see on the right side of the slide provides formula in a sterile, pre-filled bag or bottle that is spiked with tubing. In the open system, only the formula itself is sterile, not the bag that it hangs in. And with the ready-to-hang system, the entire system is sterile because the formula is not exposed to the outside environment. The ready-to-hang system is therefore preferable and associated with a decreased risk of contamination. The tube feeding formula and method of administration are determined by the doctor's order. Confirm the formula matches the order and check the expiration date. Meticulous infection control principles must be observed when handling tube feeding. Tube feeding supplies and equipment must be handled with care and changed every 24 hours. Tube feeding formulas and equipment can become easily contaminated, which can expose an already compromised patient to disease-causing microorganisms. Studies evaluating the source of tube feed contamination often come back to the handling of the formula and supplies by the nurse. What's more, contaminated enteral systems contribute to the diarrhea associated with tube feeding administration. Gastric residual volume is checked with tube feeding administration to assess tube feeding tolerance. Remember that gastric residual volume, or GRV for short, refers to the volume of fluid remaining in the stomach at a point in time during the enteral feeding. Nurses withdraw GRV from the feeding tube with a 60 milliliter syringe, usually every 4 to 6 hours. Checking GRV is only possible with tubes that are in the stomach. It is not possible with intestinal tubes. A high volume GRV is a sign of tube feeding intolerance. In addition, it increases the risk of reflux and possible aspiration. Unless the GRV is unusually high, it is typically returned to the stomach once it's measured to prevent fluid and electrolyte imbalance. Tube feeding and patient safety. A very serious but common complication associated with tube feeding administration is aspiration. One possible cause of aspiration is displacement of the tube. The tube may migrate from the intestines to the stomach, or the stomach to the esophagus, or it may coil in the posterior pharynx. Alternatively, a patient may aspirate if he vomits tube feeding either in small or large amounts and the regurgitated feeding enters the lungs. When a patient has a feeding tube and is receiving tube feeding, signs and symptoms of aspiration must be acutely on the nurse's radar. Does the patient have a new or increased moist cough? Is there a change in respiratory status? Are we noticing shortness of breath, increased work of breathing? Is there any choking or difficulty speaking? New or increased crackles in the lung? Cyanosis, decreased pulse ox, or maybe we can see the tube has moved and is coiled in the mouth. This is what a moist cough would sound like. Aspiration precautions must be strictly enforced on all patients receiving tube feeding, and the aspiration precautions are listed here. Another patient safety concern as it relates to tube feeding is infection. We've touched on this already. However, contamination of tube feeding can occur when transferring the formula to the administration set, assembling of the feeding system, or during the administration process. Measures to prevent bacterial contamination and upholding the highest infection control practices should always be the nurse's goal. Enteral misconnections. This describes the accidental connection of tube feeding system to a non-tube feeding site, such as IV lines, dialysis catheters, trach tube cuffs, and so on. This is a very serious and sometimes fatal error. Extreme care must always be used when connecting tube feeding to the feeding tube. When making the connection, trace all lines back to its origin, in other words, the point at which it exits the body. At change of shift report, recheck all your connections and trace all your tubes. This is a vital part of the nurse's assessment. If an infusion is running in error, the nurse who doesn't pick up the error is equally liable to the nurse who caused it. There should be a warning label on tube feeding systems stating that is for enteral use only and not IV use. On this slide, please note the signs and symptoms of tube feeding intolerance. Any of these findings must be reported to the doctor. Taking good care of your patient's mouth is vital to their well-being. Bear in mind, patients receiving tube feeding may not be able to take anything by mouth due to risk of aspiration. The mouth quickly becomes dry and populated with bacteria, which could in turn enter the respiratory tract. Attention to good mouth care is always important, but certainly very important when a patient cannot consume food or drink due to illness or injury. This concludes the presentation on enteral feedings.